share my experience with you and friends. So the incentive to think 3 millimeter MSIC is possible or not came when I was just seeing everywhere that Phaco surgeons are always feeling little smaller. So I said, if they can do, can the SIC surgeon do it? And it is to my pleasure and that I can do it. 3 millimeter foldable IOL. So I have shared it on many international fora. Now the temporal 3 millimeter is Phaco is well established. When I started thinking about 3 millimeter SICS, then the few things was my concern. Can I preserve the endothelium? Can I just produce less astigmatism? And what is the chances of infection in these cases? Now, with those kind of concerns, I started producing. I will just share my technique. Now the selection of cases, of course all kind of cases can be done, but preferably I selected grade 1, grade 2, grade 3, grade 4, and I excluded in this study I excluded the compromised cornea, this is pseudo exfoliations, junular dehiscence cases, glaucoma and diabetic retinopathy. I had to modify certain instrument. I was doing constantly SICS and I thought that certain instrument just came in my way. So I modified the dialer, made it little curved and the blunt portion, the tip was little blunt. So I have modified my back teeth. So the back teeth that in the front have a little hinge which holds the fragmented portion, and the viscoelastic cannula. Suddenly I thought that the round thing is occupying a lot of space, and I wanted to reduce that thing by just compressed with the artery forceps, and it became flatter. So that get me space between the endothelium and the nucleus, which I am going to show you. The first thing is that you have to, it is not for the beginners, it is people who have done thousands of SICS can venture into this thing, because every step is so precise. You must have a total control on your hand and your maneuvers. It may look messy for new people because they should not venture into it. The one thing which I wanted to share with you, that many people cut the conjunctiva as if it do not matter. Just keep that playing. No. And many times I have seen many people holding the tip of the lip of the wound, which should never be done, and the conjunctiva, see the forceps is kept on the conjunctiva as if just to stabilize the eye. So that needs a lot of your hand coordinations, and I use a 11 number bar Parker knife. It should be kept in a slanting position, half thickness scleral incision is given. Plate. And with the frown incision, it is straight with a 1 millimeter back cut I give, because it fastens two wounds. So where the vector forces can go to the periphery. Even if I am doing a frown incision, then also I give a tangential 1 millimeter back cut, because when I am introducing, it gives me a good scleral pocket. The wound size remains a good scleral pocket. The wound size remains 3 millimeter, but inside I am creating a pocket. So even if I want to have a PMMA lens implant, I can easily do through that maneuver. But it is designed to put a foldable IOL, which I do frequently. Now the Rexis, there is nothing different. The Rexis is nothing different, because on the Phaco, I want to show you that all the steps are same except the nucleus. Hula walu about Phaco and SICS. I just take out that kind of thing, that there should be only good surgeon and bad surgeon, no SICS surgeon, no Phaco surgeon. A surgeon should master everything. So that is the fundamental here. Rexis is same, but only in the SICS we have to have a bigger Rexis, about 5.5 millimeter. Now, as far as the hydrodissection play. Hydro procedures are concerned, they are same, but in this case what I say, don't proceed to the next step till the nucleus is mobilized. I have found to my horror that, so I said I can manage it, but don't try to manage. try to see that every step is followed the right way, because once it is attached behind, then once you are trying to move it, you can create a lot of damage to the posterior capsule. So I have learned in the hard way, so you don't commit the same mistake. See that if with one go it is not separating, go in a micro pulse separating thing, and try to see that the lens is fully mobile. Then you go to the next step. I bring the nucleus to the anterior chamber. I just put my before you go there, you make the eye taut by infusing viscoelastic, that is the dispersible form, not the sodium hyaluronate and all those things, because they come as a bolus and suddenly they come out, you will not be in a happy position. So in this case what I did is I pulled the rhexis margin behind and just went behind the nucleus and nudged it into the anterior chamber. So it's just with a one hand technique, and it works wonderfully. Now this is just a diagrammatic presentations, and when I am going there, I am infusing viscoelastic and positioning my vectis behind the nucleus. I create a space between the, I will show you that in a video, but I am just going through to say that the nucleus is divided. Now I am dividing into three. Earlier I was dividing into two. So my fragments are become. Now I am dividing into three. Earlier I was dividing into two. So my fragments have become much smaller, and now. So what I do, I inject viscoelastic and create a space between the iris diaphragm and the nucleus, position my vectis by the left hand on the diaphragm of iris, and once it is positioned, then I take the viscoelastic cannula and take it to the tip of the wound and inject viscoelastic and create a space between the endothelium and the nucleus. And it is absolutely go on pumping the viscoelastic and the space is maintained. So it may look like it is very close to the endothelium, but once you see in the microscope there is a lot of space. And now once it is divided, now all that remains is to take it out. And when you are taking it out, it is you are just gliding it out. It is not going towards the endothelium. So that endothelial compromise is not as much as it is seen. It will be happening. But so I studied just before coming that I have not done a great study about this. So, but the pilot project, my prospective study I did before coming. So 10 eyes of MSICS and 10 eyes of Phaco, and I followed it up for 1 month just to share my experience. The corneal edema in MSICS in 6 eyes was a little more than the Phaco. And however, the mean increase in the corneal thickness in MSICS was 62.3 plus and minus 1.2 microns, and in the Phaco it was 51.4 plus and minus 1.3. And the surgical induced astigmatism was in my series that it was 0.37% plus and minus 0.12 point diopter, and in the Phaco it was 0.45 and plus minus 0.8 diopter. So in my SICS I got less surgical induced astigmatism, and the corneal edema maybe because little mechanically it was I was maneuvering in the AC, so that edema was because of that. The Ruiz study which was done in Nepal, they got less surgical edema because they were doing they were not doing temporal, they were doing 12 o'clock and it's a 7 millimeter. They used the Phaco Hick, this Fisuk technique. So in our group, due to temporal location, the surgical location, it was quite away from the visual axis, so the astigmatism was less. And so 3 millimeter offers. The infection was also less in both the groups. Now 3 millimeter, so conclusion, 3 millimeter temporal MSICS is possible, has a learning curve, and case selection is very important. 3 millimeter temporal MSICS is compared to the Phaco and gives a lesser astigmatism and compared to routine temporal MSICS. Thank you.